as you know that nature has provided us with two kidneys which lie retroperitoneally on posterior abdominal wall at the level of T12 to L3. Now this level is important because whenever there is renal pain due to some issue, you will feel pain in this region on the back. Okay? And this area in which renal pain is felt is called renal angle, which is formed by the 12th rib and the lateral border of the vertebral column. So if a patient comes to you with the lumbar pain and you press on the renal angle and it is tender, it is a sign of renal disease. Now the basic unit of knee is nephron. And nephron is made of glomerulus, which is a capillary tuft, and then there are tubular system comprising of proximal tubule, loop of Henle, distal tubule, and collecting duct. Cross section of the cut section of the kidney, it will reveal outermost covering of renal capsule. Then we have renal cortex, in which mainly glomeruli and portion of proximal and convoluted tubules are present. Then we have medulla, which is comprised of pyramidal structures, and it contains mainly loop of Henle and collecting ducts. These, the tips of these pyramids, they are called papilla, and they open in the lesser calyces. They join together to form major calyces, and these major calyces then open into ureter, and in this way the process continues. Now kidneys, they have rich blood supply, and this is through renal artery, which is coming directly from the aorta. Renal artery, on entering the hilum, it divides into segmental branches. Then we have interlobular branches which pass through the renal pyramids. These form at the junction between cortex and medulla. And then from arcuate arteries, we get intralobular arteries. These are intralobular arteries. From here arise branches that are called afferent arterioles that provide capillary tuft to the glomerulus. And then we have efferent arteriole, which forms peritubular capillary plexus, and then there is venous end. All the veins, they run with their corresponding arteries, and eventually blood passes through the renal vein into the inferior vena cava. Now kidney has many functions, important functions in the body. Mainly these are categorized into 4. The main function is excretion of waste products in the form of urea and creatinine. Secondly, water and electrolyte balance, then acid-base balance, and endocrine function. Many hormones are secreted by the kidney, like erythropoietin, renin, vitamin D, and various prostaglandins. Kidney diseases also are a major cause of mortality and morbidity. And since there is a large reserve, functional reserve of the kidney, therefore people, they come late, and there is end-stage renal diseases most common. In addition, acute kidney injury may occur, and then there are many non-fatal diseases like inflammations, infections, cyst formation, stone formation, and then a large group of renal tumors. So we will discuss these diseases one by one. Now, kidney diseases, they are categorized on the basis of their main 4 morphological components. So we have group of diseases which are glomerular diseases, then tubular diseases, interstitial diseases, and diseases of the blood vessels. In the initial stages of disease, all of these diseases, they have distinct clinical features. But since there is a large amount of anatomical as well as physiological interdependence, therefore, if one component is affected, it will also affect other components. Therefore, in the later stage of diseases, it is difficult to distinguish them, and their features, they overlap. Now we will discuss these diseases one by one, and first of all, we will study the diseases which affect tubules and interstitium. Now, these diseases, mainly, they are of two types. Number one is inflammations, and number two is ischemic or toxic injury of the tubules. So these are the two main groups that we will discuss. Now, inflammation of the tubules or interstitium is called tubulointerstitial nephritis. And in this case, there will be inflammation of the kidney by inflammatory cells, including mononuclears, that is lymphocytes, plasma cells, macrophages. Then we have eosinophils, neutrophils in acute conditions, and edema due to the inflammatory process. Now, there are many causes in which tubulointerstitial inflammation is produced. Therefore, we require a clinical pathological correlation to reach at a final diagnosis. And there are many causes of tubulointerstitial nephritis. The main one is infection. And infection mainly is due to bacterial causes, but viruses and parasites, they can also produce the infection. Then toxins, they make a large group, especially drugs and heavy metals. Drugs, they can produce inflammation due to hypersensitivity reaction or due to granulomatous reaction. Similarly, heavy metals, they may cause inflammation in the kidney. In metabolic diseases, gout, there is high uric acid level, and this uric acid gets deposited in the kidney and causes urate nephropathy. Similarly, in hypercalcemia, there is deposition of calcium in the kidney parenchyma, and that condition is called nephrocalcinosis. Various physical factors can cause inflammation, like chronic urinary tract obstruction or radiation exposure. In various neoplastic conditions like multiple myeloma, light chains, they get deposited in the kidney parenchyma and they will produce inflammation. Then various immunological reactions like transplant reaction, Sjogren's syndrome, or sarcoidosis, we will get inflammation of the kidney. Now, out of all these 6 groups, we will be mainly focusing on the infections of the urinary tract and pyelonephritis. Now, what is pyelonephritis? The word pyelo refers to pelvis, and nephritis means inflammation of the kidney. So pyelonephritis is a condition in which there is inflammation involving renal tubules, renal interstitium, and renal pelvis. So you have to mention renal pelvis in the definition of pyelonephritis, otherwise your marks will be deducted. Okay? So pyelo means renal pelvis. Now, pyelonephritis can be acute or chronic, and etiologically, the main cause of infection of pyelonephritis is gram-negative bacilli. In more than 85% of cases, gram-negative organisms are responsible, and these are mainly derived from the patient's own gut flora. And the main culprit is E. coli. In addition to E. coli, various other gram-negative organisms like Proteus, Klebsiella, and Enterobacter, they will also produce the pyelonephritis. And gram-positive organisms like Strep, Faecalis, and Staphylococci, and other organisms can also be responsible. In immunocompromised patient, organisms of less virulence will also produce the disease, like polyomavirus, cytomegalovirus, and adenovirus. Now, what are the pathways or route of spread of renal infection? Now, this is a very important university question, and many a time you get a question to write and draw the pathways of renal infection. So there are 2 pathways. One is hematogenous route, that is, infection reaches the kidney through blood, and other is ascending infection from lower urinary tract. Now, lower urinary tract includes urethra and bladder. So infection may spread from these organs upwards, or it can reach through the blood supply. Now, in hematogenous spread, it occurs whenever there is septicemia. So if there is blood-borne infection, the organism, they will seed the kidney and will produce pyelonephritis. Sometimes in infective endocarditis, when there is localized infection of the cardiac valves, septic thrombi, they will be shed and they get deposited in the kidney and they can produce pyelonephritis. Now, blood-borne infection is more common when there is urethral obstruction, because when urethra is obstructed, the cleansing action of the kidney is reduced, and there is more risk of developing infection. Then in debilitated persons and in immunocompromised persons, there is more risk of this blood-borne infection. And these hematogenous route mainly causes infection by non-enteric organisms, in which Staphylococcus is very important. Second route of infection is ascending infection. And in this case, there is, it is a multi-step process. And the first step is colonization of the distal urethra. Now, microorganisms, they have pili or fimbria on their surface, and there are receptors which are present on the epithelial surface of the urethra. So these fimbria, they will get attached to these receptors, and then they start multiply and they will produce urethritis. Now these infections, ascending infections, they are more common in females because of short urethra. Secondly, because there is lack of defensive effect of prostatic fluid, which contains many antibacterial components. And thirdly, hormonal changes. Female hormones, they affect the adhesion of bacteria to the epithelium. Therefore, these infections are more common in females. The second step is infection of the bladder, which is called cystitis. And this occurs when there is instrumentation or there is catheterization. The infection can reach from the urethra into the bladder. Normally, urine is sterile. This is because of the continuous flushing and voiding action of the urine. And secondly, because the wall of the bladder, it produces antibacterial substances. But risk of infection increases if there is outflow obstruction. This obstruction may be due to tumors, it may be due to stones, or it may be due to enlargement of the prostate gland. Similarly, if there is bladder dysfunction, for example, if there is spinal cord injury or in diabetic patient, the bladder becomes atonic. And in both of these conditions, there will be residual urine will be present in the bladder. And this urine, it provides a site for the bacterial growth. As a result, there will be cystitis and infection of the bladder. In third stage, infection spreads from bladder into the ureter. And this occurs due to vesico-urethral reflux. And this reflux occurs because of the incompetent vesico-urethral valve. This picture shows entry of ureter into the bladder. Normally, this entry is quite oblique. And there is a long component of the ureter which passes through the bladder wall. And this component, it acts as a one-way valve, because during maturation, when bladder contracts, this valve gets closed and there is no reflux of urine into the ureter. But when this valve, it becomes incompetent, then during maturation, urine will pass from the bladder into the ureter. And this incompetence can occur in two ways. Either it is congenital. In some patients, there is congenital absence of this intravesical portion, or it is less oblique and it is shorter, so it is not closed during maturation. And as a result, there is reflux of urine during maturation. Secondly, it may be acquired. The infections and inflammations, they themselves cause dysfunction of the ureter, or if there is some spinal cord injury or some other reasons which cause atony of the bladder, this valve, it becomes non-functional, and as a result, infection can spread into the ureter. Now, this vesicoureteral reflux, it can be demonstrated by voiding cystourethrogram. In this case, the bladder, it is filled with a radio-opaque dye, and patient is and films are taken during maturation. If the this valve is incompetent, the dye will pass into the ureter, into the pelvis, and through the calyces into the kidney. But if it is competent, there will be no backward flow of the dye. So this is to diagnose the incompetent vesicoureteral reflux. And the final stage is passage intrarenal reflux from these calyces, from the ureter into the kidney. And this mostly occurs in upper and lower poles of the kidney, because here the tips of the papilla, they are flattened or concave. As in central region of the bladder, they are more pointed. So reflux can occur more in the upper and lower poles. Now, what is the morphology of pyelonephritis? This is also important university question. Whenever you are asked to write morphology, you have to write gross features as well as microscopic features, because there are separate marks for both components. So you have to write both of these features. Now, acute pyelonephritis is acute suppurative inflammation of the kidney, which means that in this case, pus is formed in the kidney. So on gross examination, you will see multiple abscesses in the kidney, unilateral or bilateral. You can see these yellow spots. These are collection of pus. And pus, as you know, is comprised of WBCs, dead and dying WBCs. They are bacteria, and there is degenerated or necrotic material of the organ which is involved. So you will see multiple abscesses. Now, this picture is also very important for your OSPE. Many times you are given this picture in OSPE and various questions are asked. So you must study it carefully. On microscopic examination, you will see acute inflammatory cells, that is neutrophils. And these neutrophils, initially, they are present within the lumen of renal tubules. Then they will pass through the renal tubules and cause its damage. So there will be tubular necrosis. And even last of all, they will pass into the interstitium. So you will see patchy infiltrate of acute inflammatory cells in the interstitial tissue. This picture shows, this is glomerulus. These are normal renal tubules, and this is a focus in which pus formation has occurred. These blue dots, they represent neutrophils, and you can see that tubules in this region, they have necrosed, they are damaged, there are no tubules. So this is a focus of pus formation in the kidney. If acute pyelonephritis is treated early, it can be cured. But if treatment is not given properly, it can lead to various complications. And the most important complication is papillary necrosis. This is a condition in which papilla, they undergo necrosis. The reason being that papilla is a very delicate structure, and its blood supply is also very sensitive and very delicate. So due to infections, these vessels, they get damaged. There is ischemia of the tips of these pyramids and results in coagulative necrosis. Now, this papillary necrosis is more common in diabetics, because in diabetic patients, risk of infection is more. Secondly, they already have small vessel disease, that is capillary disease. So they are at more risk of getting damage and getting ischemic. Similarly, in case of urinary tract obstruction, there is back pressure in the kidney, and there is pressure on the vessel, causes ischemia, and this will add to the insult and result in necrosis. There's another condition that is sickle cell anemia, in which papillary necrosis is common. Because in sickle cell anemia, sickle cells, they will block the papillary, the vascular lumen, and they cause ischemia, and they increase the risk of necrosis. So these are pyramids, and this is the tip of pyramid which has undergone necrosis. So the area becomes grayish brown in color. And this is the microscopic examination, in which coagulative necrosis is present, the architecture is preserved, but nuclei are lost. And you can see just dark eosinophilic material in this area. This is ischemic necrosis of the tip of papilla. Second complication is pyelonephrosis. Pyelonephrosis means pus in the kidney. You can see this yellow area. This is accumulation of pus in the kidney, and this is a specimen of kidney which has been cut open. This obstruction in the ureter, and due to obstruction, pus cannot be drained. As a result, it gets accumulated in ureter, pelvis, and this is called pyelonephrosis. Third complication is perinephric abscess. Normally, inflammation or infection, it is contained within the kidney because of the presence of renal capsule. But when the infection is more severe and there is more pus formation, it can penetrate the renal capsule, and so the pus can spread into the surrounding areas, resulting in perinephric abscess. Now, patients of acute pyelonephritis, they present with sudden onset of pain, and pain is present in costovertebral angle, and if you apply pressure in this angle, it will be tender. So it is a diagnostic sign for the renal pain. In addition, patients have fever and malaise, and due to the involvement of bladder and urethra, there will be dysuria, that is burning maturation, frequency, and urgency. Then pyuria. Pyuria means presence of WBCs in the urine. So if you do microscopic examination of urine, pus cells will be present. But from these pus cells, you cannot differentiate whether they are coming from lower urinary tract or they are coming from kidney. To differentiate this, you will have to look for the leukocytic cast. These are the collection of WBCs in the renal tubules. So these presence of cast is a confirmatory sign that kidney is involved in infection. And the gold standard for pyelonephritis is urine culture. And culture is done to isolate specific organ. And then we apply a sensitivity test to find out the proper antibiotic. So if you give proper antibiotic treatment to the patient, you can completely get recovered. Chronic pyelonephritis occurs when acute pyelonephritis is not resolved. So it is characterized by chronic inflammation, and as you know, in chronic inflammation, you have chronic inflammatory cells like lymphocytes, plasma cells, macrophages, and there is renal scarring, and due to scarring, there is damage of the pelvis and calyces. And this chronic inflammation occurs due to recurrent urinary tract infection, and it can lead to end-stage kidney disease. Mainly, chronic pyelonephritis occurs due to two mechanisms. One is chronic reflux-associated nephropathy, and second is chronic obstruction of the urinary tract. Now, in chronic reflux nephropathy, it occurs mostly in patients who have congenital defect in the vesico-ureteral valve. And so it is present since childhood. It can be unilateral or it can be bilateral. And in this case, because there is residual urine, so patients develop recurrent attack of acute pyelonephritis, and they cause damage of the kidney that result in chronic renal insufficiency. Second cause is chronic obstructive pyelonephritis. So obstruction of the urinary tract due to any lesion, for example, it may be posterior urethral valve, or it may be due to or it may be due to ureteric anomalies. All these conditions, they cause obstruction. Obstruction leads to stasis, and stasis predisposes to infection. So due to chronic infection, there is chronic damage and chronic inflammation, resulting in chronic pyelonephritis. Morphologically, on gross examination, the main feature is asymmetrical irregular scarring of the kidney. Now, this feature is demonstrated as irregular surface of the kidney. Kidney, due to scarring, its surface has become irregular. Now, this is to be differentiated from scarring due to chronic glomerulonephritis. एक और condition है जो बाद में पढ़ेंगे, chronic glomerulonephritis. In that case, there is very uniform distribution of scarring. But in chronic pyelonephritis, scars, they are irregular in appearance. So this is cut section, this is scarred area, this is normal kidney, this is scarring of the area, and due to scarring, the underlying calyces and pelvis, it becomes deformed. So if you take radiographic examination, if you perform radiographic examination, you can see abnormal pelvic ileal system, and it is a quite diagnostic feature of chronic pyelonephritis. On microscopic examination, whenever you comment on microscopy of the kidney, you have to comment upon all four structures, that is tubules, glomeruli, interstitium, and blood vessels. So in chronic pyelonephritis, what happens with the tubules? Because it is a slow process, so tubules, many of the tubules, they undergo atrophy, that is, they become smaller in size and their epithelium becomes flattened. Sometimes they are dilated, and these dilated tubules, they are filled with a colloid-like material. This is actually proteins which are present in the urine. And when you stain them with H&E, they appear pink. And this pink eosinophilic material, since it resembles colloid of the thyroid, so this picture or this appearance is called thyroidization. It is not colloid material. It is the proteins which are deposited, which are present in the kidney, and they resemble colloid material, so they are called thyroidization. This is a very important feature which can you see on microscopic examination. And you have a slide of chronic pyelonephritis. Many times you get in your exam. So this thyroidization is a very diagnostic feature. So this is thyroidization. You can see tubules of variable sizes. Okay, here small tubules and these are atrophic, or यहाँ पे these are dilated tubules, and they contain these eosinophilic pink material. This is actually proteins which are present in the urine, and they stain pink with H&E. And due to this appearance, this is called thyroidization. Second component, interstitium. In the interstitium, you will see inflammation and fibrosis. And since it is chronic inflammation, you will see lymphocytes, plasma cells, and macrophages. And the fibrosis means that in that area, the tubules and other structures, they will be damaged and they will be replaced by the fibrous tissue. Glomeruli in the initial stages, they remain almost normal. There is mild periglomerular fibrosis. But in later stage of the kidney, when marked fibrosis is present, in that stage, glomeruli also get obliterated by fibrous tissue, and this condition is called glomerulosclerosis. So these blue dots, they represent chronic inflammation. ठीक है, तो in इस area में आप देखो कि आपको कोई भी tubules नजर नहीं आ रही. Tubules are present in the other area. So in this area, there is inflammation and fibrosis. And this is glomerulus. It is almost normal. There is mild fibrosis around the glomeruli. And in the late stage, the glomeruli, they also get sclerosed. So this is glomerulosclerosis, which occurs in the late stage of the disease. And vessels, Uh, Sometimes when patients develop hypertension due to kidney damage, in this case, vessels, they will show hyaline arteriolosclerosis, which means that vessels, they get narrowed because of the deposition of hyaline material in their wall. And this condition is called hyaline arteriolosclerosis. Arterioles, they get sclerosed because of the hyaline material which is deposited in their wall, and vessels, they become narrowed. So these are the vessels, ठीक है, और इनकी ये वॉल के अंदर आपको थिक वॉल्स जो है नजर आ रही हैं बिकॉज ऑफ द hyaline arteriolosclerosis, and these are the renal tubules which contain pink material, ठीक है. Now, chronic pyelonephritis, since it is a slow growing process, therefore, patients, they are presented late in the course of disease. And they have recurrent attack of acute pyelonephritis because of either blockage in the urinary tract or due to reflux nephropathy. On urine examination, bacteria and pus cells may or may not be present, and tubular dysfunction is present, and this is in the form of polyuria or nocturia, because tubule main function concentration of urine does not occur. Therefore, this results in polyuria or nocturia. And radiological images are very important because they will show disfigured or damaged calyces and pelvic area of the kidney. And in the late stage, when glomeruli also get sclerosed, then patient will develop chronic kidney injury or chronic renal failure. There is a specific form of chronic pyelonephritis which is called xanthogranulomatous pyelonephritis, and in this case you will see foamy macrophages in the kidney in addition to plasma cell, lymphocytes and neutrophils and giant cells, and this occurs especially when there is proteus infection and there is obstruction. On microscopic examination, these pale cells, these are the xanthoma cells. These are actually macrophages containing various lipid material, and this entity has to be recognized because it can be mixed with some tumor or some other process. So you must be familiar with this entity. So that was all about acute and chronic glomerulonephritis. Next time, inshallah, we will discuss acute kidney injury and other diseases. Thank you very much. कितनी देर लगी इसमें? 10 minutes करते हैं अभी. मैं एक और टॉपिक कर सकती थी. चलो.